Hello, everyone. I'm Dr. Saydra Wilson, and I will be moderating our session on ensuring equity in neuromodulation access. This section is meant to be very interactive, so we will only have 2 speakers and then a large open discussion section at the end, because I hope that this audience contains various stakeholders in the neuromodulation process: patients, clinicians, engineers, other researchers, so that we can have a deep discussion about these issues of equity. I'll start with introducing myself. Like I said, I'm Dr. Saydra Wilson. I am an adult psychiatrist. I'm a clinician researcher, and I identify as an interventional psychiatrist, meaning I use procedural treatments to treat difficult to treat depression. I am an active user of transcranial magnetic stimulation and electroconvulsive therapy, and have programmed vagus nerve stimulation devices in my clinical care. In my research program, I look at methods to enhance transcranial magnetic stimulation treatment response by personalizing treatment and developing new protocols, as well as looking at patient-related factors that affect clinical response through retrospective studies. And my final area of research is mental health treatment disparities in neuromodulation, and you'll see a little bit of my work included here and in the poster session tomorrow. And so with that out of the way, we'll get started. We'll start with a few definitions so we all start on the same page. Equity is the quality of being fair and impartial, and it differs from equality in that it acknowledges that everyone does not have the same needs or the same starting point. BIPOC refers to Black, Indigenous, and people of color. Racialized means to be categorized, marginalized, or regarded according to race. And the definition of neuromodulation we'll work with today is technology that alters nerve activity through targeted delivery of a stimulus. Neuromodulation is the result of rigorous translational research, the process by which basic science understandings are transformed into clinical treatments and released out into the world to have public health benefit. There are multiple stages to translational research. T0, or basic research, T1, or preclinical or proof of concept research, T2, clinical research, T3, clinical implementation or outcomes research, and in T4, translation to public health and population level health improvements. Hopefully, by using a series of case studies and examples, by the end of this section, I can promote some discussion and try to get you guys to sign on to the belief that access to care can be facilitated at all stages of translational research. The first area that I'm going to talk about is applicable to all stages of translational research, and that is improving access through science workplace diversity. Our first case study is in transcranial direct current stimulation, or TDCS, which uses a constant low direct current delivered via electrodes to the head to change neurological or psychiatric illness. This technology has not been very accessible to people of color because for many years, African Americans with dreadlocks or cornrows were excluded from TDCS studies due to concerns that the electrodes contact would be inconsistent and not reliable, and that hair oils or thick braided hair could cause excessive electrode movement and change how the current is delivered to the brain. It was only in 2022 that a first case report was made using TDCS clinically in a stroke recovery patient at a VA hospital, where they were able to demonstrate that they could keep the electrodes in place with slightly different positioning and still maintain an electric field that provided clinical response with dreadlocks in place. There's a similar story in the world of EEG, or electroencephalogram, which is the recording of the electrical activity of the brain. This procedure requires electrodes consisting of small metal discs with thin wires pasted to your scalp. And they often found that data quality was poor in dealing with African Americans who are more likely to have a phenotype of coarse and curly hair because it prevents access to the scalp. Etienne and colleagues developed a program in which they encouraged African American patients to style their hair deliberately to expose the scalp using a standard hairstyle called cornrows. And then they strategically placed the parts in the hair where the electrode locations were in order to make better contact, as well as developing the SIVO electrode, which is a special clip seen in that center picture that hooks into the cornrows, holding the electrode more firmly in place. They were able to directly test that these electrodes improved data quality. In that bottom right chart, we're looking at impedances, meaning the impediment of the electrical flow. So when the impediment is high, poorer data quality. When the impediment is low, better data quality. So unrestricted, unbraided hair with the standard electrodes is in blue, has the highest impedance. And then braided hair with the standard electrode is in orange, stepping down. And the least impedance was in braided hair using their special SIVO electrode. So what do these case studies have to do with science workplace diversity? So the presence and participation of BIPOC researchers in these two research groups influenced the development of a more inclusive neurotechnology. And it was part of the reason why these techniques were modified and developed in the first place, because the researchers who were studying them couldn't use them themselves. We do have some information about solutions to improve science workplace diversity. These are the recommendations from a recent paper to be published in the American Journal of Psychiatry, Structural Racism in Psychiatric Research Careers, Eradicating Barriers to a More Diverse Workforce. And these recommendations include comprehensive early career research experiences for underrepresented minorities to help them navigate the pipeline into extensive training, targeted mentoring opportunities for underrepresented minorities, the greater use of diversity-related supplements for funding, re-entry and practical training for those students who get off track to maintain their progression to the next stage of education, cohort building, or building critical mass of underrepresented minorities in specific training programs to decrease stereotype threat and produce a sense of welcome, reducing overall environmental bias, and doing standardized outcomes research that tracks what is successful in training programs that have a lot of underrepresented minorities. Next, we'll move on to the T1 and T2 stages of translational research, and we'll look at improving access by eliminating research participation disparities. Our case study here is with vagus nerve stimulation, which you've heard a lot about so far this morning. In this case, we're talking about the implanted device that sends regular mild pulses of electrical energy to the brain via the vagus nerve. Currently running is the RECOVER study, the largest prospective randomized placebo-controlled trial using vagus nerve stimulation to treat major depressive disorder. And here is a copy of their recent demographics table from the February Neuromod conference. You'll see in the center column that 94.4% of the participants in this US Medicare study were white, and only 2.4% were Black or African American, 1.8% were Asian, and 0.7% were listed as other, and 0.7% were non-reported. This is out of proportion with the US population, where we expect 61.6% of the US population to be Caucasian. This suggests that there is a research participation disparity with VNS. Some of you may say, well, yes, I would expect that. VNS is an invasive neuromodulation therapy, and potential participants of color are shown to have lower trust in the healthcare system and may be less likely to be involved with any type of invasive care, whether it's experimental or clinical. But we also found that this research participation disparity held true in less invasive techniques such as transcranial magnetic stimulation, which is my specialty. So TMS is an outpatient device that induces high and low intensity magnetic fields in specific brain regions to modulate cortical excitability. It's been FDA approved since 2008 for the treatment of major depressive disorder that has failed to respond to at least one antidepressant. So we investigated a possible disparity in research participation for this non-invasive device through a systematic search of the literature, and we looked at US-based clinical trials whose primary outcome was major depressive disorder clinical response. So none of the biomarker studies, only clinical response studies. And we found 122 US-based trials within our search parameters. Unfortunately, only 20% of those published works reported the racial demographics at all. In those that reported racial demographics, white populations were overrepresented in 96% of the studies included in our analysis. Once again, meaning that Caucasians made up more than 61.6% of the study population compared to the US Census population from 2020. This overrepresentation was apparent across all major US regions. To the right, you see the graph of the racial demographics of the participants in our pooled analysis, which was 1,227 people who received RTMS for depression, split up by region. The black line represents the proportion of racialized persons expected in that region. Racialized meaning anyone who was Hispanic and non-white and all other categories. If they were given proportional representation inside the trial, the red bars would be as tall as those black bars in every region. So it's not just the invasiveness of the neuromodulation technology that predicts whether there's going to be a research disparity. So how can we improve recruitment in clinical trials for underrepresented minorities? Andresi and Fletcher suggested some specific techniques, as well as creating this infographic that talks about all the different things that interfere with clinical trial enrollment, from things like health literacy, awareness of the disease, receiving a diagnosis, access to care through insurance, referral to specialized centers, physician recommendation to reach a clinical trial, and then the necessary resources such as transportation and free time to participate in a trial all can impact who is participating in clinical research as a whole. To recruit underrepresented minorities, they recommend proactive targeted study design and advertisement to these communities. They recommend designing community-engaged studies in which specific community and partners are part of the planning and implementation process of the research and sometimes even generate the actual research questions. And then it's important to engage minority-serving community physicians as the entry source for trial recommendation because they're already serving the community. And overall, they recommend that you base future solutions on research in the populations of interest where you explore what barriers and facilitators there are to clinical trial interactions. Now we'll move on to T3 and T4 stage research, which involve treatment. So we'll talk about eliminating treatment access disparities. And treatment access disparities are multifactorial. I tried to group them into 5 potential categories that we're going to talk about next. So treatment access disparities are impacted by patient awareness and knowledge of the treatment, patient selection or physician gatekeeping of the treatment, finances or insurance access for the treatment, the geographic distribution of the treatment, and stigma and acceptability. I'm going to wave my hands over the awareness and knowledge section because you're going to hear more about this in the second half of the session with Dr. Cabrera, or you can work with my colleague Christy Sullivan at our poster session tomorrow and look at some of our focus group data, which gives us feedback directly on the awareness of TMS in the BIPOC community in the Twin Cities, as well as some acceptability information. So we'll move on to patient selection and gatekeeping. Our case study for patient selection is electroconvulsive therapy, which uses a brief electrical stimulation of the brain while the patient is under anesthesia to treat psychiatric and neurological diseases. We know that physician bias can impact who is recommended to have electroconvulsive therapy. Thus, the physicians are selecting the population for treatment. And provider racial bias has been documented to have a higher misdiagnosis in white-black cross-cultural communication about mental health treatment. The quote says, patients of color were significantly more likely than Caucasian patients to receive ECT when diagnosed with having schizophrenia than they were when they were diagnosed with having depression. And depression is the primary indication for electroconvulsive therapy. The rates were 4 times higher for Black patients and 2 times higher for Latino, Asian, Native Hawaiian, and Native American patients, suggesting that patients of color were more likely to be recommended ECT when they were given a psychosis diagnosis, but they're also more likely to be misdiagnosed, and thus they're sent at uneven proportions to the treatment. We'll move on to finances and insurance access. Our case study for finances is deep brain stimulation, a neurosurgical procedure that uses implanted electrodes and electrical stimulation to treat movement disorders associated with Parkinson's disease, essential tremor, dystonia, and other neurological conditions. Who your insurance provider is can predict your likelihood of whether you can get DBS treatment. So what you see here are 3 charts, with the leftmost chart representing public insurance, Medicare or Medicaid, the center chart representing private insurance, and the last chart representing other group, which also includes cash pay patients. And what you're seeing is the rate of people getting deep brain stimulators per 100,000 of the US population. The good thing about this data is that it shows access over time, before and after the initiation of the Affordable Care Act. Overall, the Affordable Care Act increased access to DBS implantation, especially in the Medicare and Medicaid population, with a slope of 2.4 after Affordable Care Act implementation. There was less of an impact on the privately insured with a slope of 0.08. And there was a small but positive improvement in the slope of the other or cash group with a slope of 0.77. We can all agree that it shouldn't matter who your insurance provider is to get function improving necessary care for a lifelong condition. Next, we'll move on to the impacts of geographic distribution of care. And this is, again, another case study of deep brain stimulation. So the zip code that you live in also predicts whether or not you can get DBS implantation care. The socioeconomic status of your zip code is a predictor, and after adjustments for demographic and clinical covariates, neighborhoods with high socioeconomic status were associated with a 1.4-fold higher odds of receiving a DBS just based on how rich the people around you are. This is demonstrated in the table in that first column, where in the least affluent group, only 1,152 people had DBS implanted, compared to in the most affluent area, 3,577 DBS implants were made. They also found that these are Medicare beneficiaries, and if these were Medicare beneficiaries who were treated in clinical practices that were predominantly minority serving or in areas where they treated a lot of minority patients, whether they were white or black, were less likely to receive DBS coming from those referral sources. Here's a more traditional impact of geography on care with electroconvulsive therapy. Once again, a procedurally based form of neuromodulation. That means you need to come to a hospital or surgical center location to receive your care, and thus it's very geographically bound. For those of you who follow ECT research, you know that the number of ECT providing hospitals has been decreasing over time, and you can see in that upper chart the number of hospitals in pink and the percentage of hospitals that are offering ECT services above in black. Dr. Jones, in their thesis research, mapped the state of North Carolina where they were studying, and they mapped the location of the primary ECT treatment site along with the population densities of different racial and ethnic groups across the state. And you'll see that the darker the color, the higher the population density of that racial or ethnic group, or the larger the circle. And as you can see, the areas that are best represented by the treatment center for ECT is in that bottom row of non-Hispanic or non-Latino or white and Caucasian participants in the state of North Carolina. This suggests that ECT providing hospitals are not distributed based on BIPOC population density, which can impact the number of patients who are able to participate in care. And lastly, we'll talk about how stigma and acceptability can impact treatment access disparities. Back to our good old friend vagus nerve stimulation. You guys may be aware that VNS has multiple indications. VNS, yeah, sorry, you guys are experts. So VNS has been FDA approved since 1997 as a use for an adjunctive therapy in reducing the frequency of partial onset seizures in those that are refractory to anti-seizure medicine for patients 12 and older. But they're also approved for major depressive disorder since 2005 for those with unipolar or bipolar depression with a history of failure to respond to at least 4 antidepressants. These are 2 separate illness groups that benefit from VNS, and yet there is an extreme difference in the number of implants that are actually performed. There's approximately 120,000 implants for epilepsy, but only approximately 5,000 implants for major depressive disorder. Is it possible that stigma associated with the illness indication is impacting this treatment utilization? And how do we start to modify that stigma? Because even with a slightly less than 10-year head start, I don't think the differential should be this large. I hope that I've given us a framework to have a deep and thorough discussion after the second speaker. And I'd like to thank my mentors, my collaborator, and my research team for all their hard work. Let me just bring my notes up, and it will be my pleasure to introduce my collaborator, Dr. Laura Cabrera, and the second speaker of our session. So Dr. Laura Cabrera is the Dorothy Huck and J. Lloyd Huck Chair in Neuroethics and Associate Professor at Penn State University. She has the unique training background of being an engineer as well as a PhD neuroethicist, and she combines those interests in exploring patient attitudes and acceptability towards invasive and non-invasive neuromodulation therapies. She has a faculty appointment in the engineering school as well as the bioethics department, and she is a robust member of her professional societies, including IEEE and the International Society for Neuroethics. Please welcome Laura.
Okay, so thank you, Dr. Wilson, because she did a great introduction in like really setting up some of the discussions. I won't need to introduce the technologies or anything, but I can just really dive into some of the more juicy parts of my talk. So I've been doing research, and what part of today's talk is trying to present some of the data that I have with other neuromodulation interventions, and leave it for the room today to also start thinking, well, how can we draw from that lessons in terms of vagal nerve stimulation? But let me start a little bit, and this is minimal because Dr. Wilson already did a great job there, to talk about barriers in mental health. So we know that at different stages and different stakeholders, so we know that providers, patients, and caregivers encounter barriers to providing and receiving care in a timely and effective manner. Now, let me describe two types of barriers. So on the one hand, we have structural barriers. Those would be barriers that have to do with availability of the services, as Dr. Wilson presented. There are barriers that have to do with the administrative challenges, which like, for example, with insurance. There are barriers about limited resources. Not everyone can afford to have, perhaps, to buy a TMS machine. So those are barriers on limited resources. And there's a cost of equipment, right? So again, not everyone can afford to have in their clinic certain type of interventions. But there are also attitudinal barriers. And those can be really important. So Dr. Wilson already said stigma. You would think, well, maybe that only applies to ECT, but as she showed in one of her slides, is it? Maybe it's not the same type of a stigma, but we need more data to really be able to conclude that stigma is or is not part of the equation here. There are issues also about fear of treatment or negative health belief. So if we go, for example, in the case of electroconvulsive therapy, a lot of patients and even some providers still think that, well, there are important memory impacts after ECT. Data doesn't show that that's true in terms of like being as drastic as it's portrayed. So again, it can be a negative health belief that doesn't really correlate with what we know. There can also be misinterpretations or uncertainty about treatment consequences. Again, so this relates a little bit with some of these negative health beliefs. And as Dr. Wilson already mentioned as well, the referral patterns by psychiatrists and other clinicians can be a reflector of these attitudinal barriers, right? Is it because there are bias there? Is it like a fear that patients, or rather not fear, but like a belief that maybe some populations won't follow through, the course of treatment? So again, some of these beliefs and attitudinal perspectives can be important barriers in treatment and care. And also some perceived ethical issues. So as part of the talk today, I'm mostly going to focus on barriers, but ethical issues can be both, barriers and facilitators. So from time to time, I also will weave in some of these as part of the talk. But let me describe you this project that I've been, conducting for over 4 years now, where we try to really assess the perspectives from multiple stakeholders, so including psychiatrists, patients with depression, caregivers, and the general public. But we also try to look at it from different interventions. So we look at electroconvulsive therapy, transcranial magnetic stimulation, deep brain stimulation, and adaptive brain implants, or also closed-loop DBS. And I think this is one of the first projects that really tries to look at this issue in a more holistic manner, a more inclusive manner, try to look at the same time multiple interventions, multiple stakeholders. No easy feats, but it was something that we thought it was important. Now, some of, especially reviewers, have asked us, why those 4 interventions? When we designed the grant, we thought, okay, we want a variety, a diversity of interventions So we want to have some interventions that are already approved, like ECT and TMS. DBS and ABI, mostly for at least depression, they are still under clinical trials. But we also want to have interventions that have different technological features. So in the case of electroconvulsive therapy and TMS, you don't have anything inside your skull, so that's a clear difference with DBS or ABIs. ECT, so just the electrodes do touch your skull. With TMS, it's a little bit more separate, but it's still, it's more magnetic in nature. So again, we wanted to have this variety of things to be able to tease apart. Well, these are all part of what, I think early in the opening remarks, this has been called electroceuticals. But how are all these electroceuticals? Are the perceptions of electroceuticals the same across electroceuticals, or are they not? And so that was partly, again, why we chose to have this variety. The project, which tried to determine factors shaping the psychiatrists, patients, and members of the public ethical concerns, beliefs, and attitudes around these interventions. Now, something I think is important to remember is that partly a lot of the funds and more research into this type of interventions was because we clearly saw that a group of patients was not being benefited by just conventional drug therapies. So we needed to find other ways to help those populations. We also know that there was a greater public awareness of the lifelong burden that comes to the patients, but also the caregivers to those patients. So again, we need to do something for that. But let's not forget that there's also a lot of stigma around these interventions. So far, no one has mentioned one flew about the cuckoo's nest, but clearly, this is something that even current research keeps showing as being part of the public mind. And it's just really interesting how certainly still put a negative lens on electroconvulsive therapy, but it is not out of the question that some of this knowledge can also translate into other electroceutical interventions. And partly, because the media, the popular culture tends to portray this intervention, electroconvulsive therapy, as primitive and ineffective instrument of social control. And again, this largely impacts the public disapproval of ECT. So again, we've seen how in particular states, there's even more and more trying to regulate and make less accessible electroconvulsive therapy. So in addition to what Dr. Wilson mentioned of less hospital offering it, it's just the structural barriers of the administrative challenge to even get certain populations have the access to this. All right, so we'll try to work quickly to some of the data. So the first phase of our project was a developmental stage where we carry out interviews. One of the reasons why we did that is because really there was not much data on the topic, so we really need to have a baseline. And so we conducted interviews with psychiatrists, patients, and the public, and we tried to have a good variety of experience. So we interview psychiatrists that have experience with electroceuticals, as well as psychiatrists that didn't have that experience. Similar with patients, we interview patients that have experience with electroceuticals and patients that didn't. And in the case of the public, we tried to capture experience of people that were caregivers and people that did not have that experience. For each of these participants, we asked them about one or two of the interventions that I previously mentioned. And some of the things that we tried, so this was the interview instrument was a little bit long, but really trying to capture a variety of important neuroethical aspects, from what is the affect of the attitudes to these interventions, to issues about invasiveness, changes to self, which is a big topic in the neuroethics literature, questions about risks, about the benefits, about barriers, or the perceived barriers in some cases, and also the ethical issues. Now, I don't have time to go through all of the data, through all of these different measures that we have here, but I'll show you a key examples before I move to the national survey, which is what the project was really keen to do. So in terms of structural barriers, I just want to share some of the quotes that we have from our participants. So this first one says, well, most insurances don't seem to cover TMS, and patients have to pay out of pocket. So we know that there is parity at the federal level, but there's no parity for all states. So some states it's more difficult. And clearly for this psychiatrist, he was just having really problems, all the paperwork I have to do to convince insurance that this patient is eligible. So that was a structural barrier there. And this was from a patient that says, well, I was having a hard time finding a psychiatrist up here. There is a real lack of psychiatrists, right? So even finding clinicians, psychiatrists that have, that can perform these interventions is not, equally distributed in different geographical areas. Now, and so one important reason why we care about access is because they can worsen the health-related inequities for many of the world's most structurally disadvantaged populations. So it's not only important that, yes, we know that there are barriers to access, that people get affected, but also who really gets affected, right? So if these barriers to access have more impact in certain group of populations, then that's a question for social justice that we need to keep asking ourselves how to better address and improve access, in this case, to those populations. But there are also attitudinal barriers, as I mentioned earlier. So in this case, this patient is saying mental health care isn't as easily accessible as it should be, which I believe is a huge part of the stigma, because if it were more well accepted, then it would be a lot easier to access health care for that. And this is a quote from a psychiatrist that says, the biggest barrier continues to be the public knowledge and public perception. So just to show how the attitudinal barriers do take or are an important part of barriers in general. Now, I want to also bring here the question about invasiveness. I know Dr. Wilson mentioned in her talk, but I think it has really interesting implications, but because when we think about some of the interventions that I mentioned, so ECT, TMS, DBS, how do we draw parallels or lessons in the case of vagal nerve stimulation, then I think it's important that we start asking the question, what about invasiveness? Now, generally in the medical literature, when we talk about DBS, clearly invasive. When we talk about ECT or TMS, most people would say non-invasive, but is it? And so during the course of the interviews, one of the things that we wanted to really tease apart was, well, we talk about invasiveness as this, physical invasiveness, something that is peering into my skin, right? So that's like the traditional definition, I guess, in medical development. But some of our interviews, what patients were telling us is that there was other views of invasiveness. So some people talk about it, how invasive it was to their lifestyles to have to go every day of the week for 3 to 4 weeks to get treatment. So that was very invasive for them. Other people talk about the psychological and emotional invasiveness of having this type of brain implants in the case of DBS. So we really learned a lot from our participants that maybe, we've been talking about invasiveness as it was just, black or white. But there's like this spectrum of invasiveness that we haven't really started talking and discussing in the, with our patients or in the literature. So I have a couple of examples. Here, a member of the public says, well, when I think about invasive, I think about like a procedure that actually has to break through the skin and it has to get into the body. And here we have a psychiatrist saying, well, along the continuum of medication plus talk therapy and then TMS and then ECT, I think you get more and more invasive as you go along down the continuum. So again, this perception or this perception that is by degrees, it's not black or white. What about lifestyle invasiveness? So here we have someone that's saying, well, ECT is more invasive in terms of sort of acute side effects, but I think TMS is in some way more invasive in terms of the scheduling requirement. So again, sometimes we forget, what does it mean for someone's life to have to go that often for that long, right? And then in terms of emotional or psychological invasiveness, this member of the public, he's comparing DBS to psychotherapy. He's saying, well, they are invasive in different senses. Medically and physically, DBS is more invasive. But it doesn't really go into a patient's personal thoughts or inner self. So I think in that sense, it's less invasive than psychotherapy. So I think considering all of these different perspectives of invasiveness is important, because maybe someone is less likely to want to go and open up to a psychiatrist in therapy than just put the implant in my head, right? So we need to take account all of these different, preferences. I don't have time to go through all of this, but I also wanted to show that there's different factors shaping invasiveness, and I think some of them are really important when we think of the lessons to be drawn with vagal nerve stimulation. So for example, we know that the perceived capacity of an intervention to result in harm could shape our views on invasiveness. We know that how localized the effect of the intervention is can also shape whether someone sees something as invasive or not invasive. The amount of control retained by the person after receiving the intervention also shape those perceptions of invasiveness. How permanent the effects are perceived to be also seem to shape perceptions, and how familiar it seems to be. So here I removed the quote just because of the sake of time, but there was a patient saying, well, DBS reminds me like a Fitbit, like something, so it was interesting that he drew this similitude, but he seemed to be more okay with trying just because he had something that he could draw experience from. Whereas, for example, when we talk about TMS, it's really hard to come with a good analogy to tell to a patient, and so that aspect of not being able to bring familiarity could also be, a perceived barrier. All right, so now let me move to the survey part of the project that I want to share with you. So most of the questions were about similar issues about, invasiveness, changes to self, affect, but we clearly wanted to be able to draw, since this was national survey, what are the differences between treatment modalities? What are the differences between the severity of depression? So in our vignettes, we have patients with severe depression, and some others have moderate depression. And then we wanted to see whether, we would find an important difference depending on the stakeholder group. So we were very lucky because we got samples over 1,000 for our non-clinical groups, so both members of the general public, caregivers, and patients. And we got over 500 of board-certified psychiatrists, which is not, easy, I can tell you. It was really hard to get them, but ours is one of the largest samples of psychiatrists that we have. So, that gives us some confidence in the data. In terms of the survey, we had an embedded vignette experiment where we have the 4 interventions that I mentioned earlier, the 2 degrees of severity in a full factorial design. So that means that a participant will receive randomly one of these combinations. And what they saw was a video vignette where a psychiatrist would have this conversation with a patient about, well, I think it's now time for you to try X, right? And so it was a short video vignette, but we're trying to make it a little bit more realistic for some of the participants. Since remember, they were all from different backgrounds. They could be psychiatrists, but they could also be members of the public. We use Qualtrics to administer the survey, and we have different scales that we develop, and we're informed by the data from our interviews. And we, depending on the scale, we conducted ANOVAs or regressions. So this is a quick overview of our demographic characteristics. So for example, you can see that psychiatrists were older than the rest of our samples. We didn't reach clearly in the racial group. It's not great, but certainly we're in the 80, 88, 82. So it's a little bit better than 94% white, right? So we really try hard to try a diverse sample here. All right, so I'm going to move into the questions, the question that we ask our participants about barriers. But remember, we have data for all of the other things, and some of them are in line to be published or are under review, so hopefully you'll be able to see more of that data in the coming months. So again, these factors that we pick here are informed by the interviews, but also by the literature on these different interventions. So one of the things that we measured was limited evidence of treatment effectiveness, the lack of understanding, the out-of-pocket cost, the lack of insurance coverage, low public trust in the medical system, treatment is not available in all geographical areas, stigma, and frequency of treatment. So I'm not going to spend a lot of time in the logistic regression data. Here is considering all the interventions, but by different stakeholder group with the reference group in the psychiatrists. What I want to draw your attention is the low public trust. That's the one where there's a huge difference compared to the others. In the others, I mean, there's important things, but I just want to really to focus on that one because it's in the logistic regression is when we can really see the changes. When I present you the rest of the data, it's not going to be as obvious, but certainly something that we need to start again peeling more carefully. What are the differences by stakeholder group and when we account for other sociodemographic factors? All right, so now I'm going to I expect a little bit more of interactivity here, so don't be shy. There's no right or wrong questions or answers. So from the 8 that I mentioned earlier, what factor do you think psychiatrists pick as the most important barrier to electroconvulsive therapy? Yeah, there's no right answers. Awareness of the therapy. Well, that was not one of our factors, but maybe. Yeah, I did miss. I should have put that. Any other that some people remember from the, let me see, stigma. Yeah. So for psychiatrists, stigma was the #1 barrier to ECT, right? So that's like the psychiatrists are the purple one, patients are the pink bar. And the reason for the different shades is because we asked them about their top 3, so they could rank the first, the second, and the third. And we just try to show, for people that are interested, what is their top 1 versus like when you take into account altogether the top 1, second, and third, they still stigma is the one that wins, so to say. But the other important aspect that I want to, like now, if we move to, now the psychiatrist, what was the important thing for the patients? And the reason why I don't have the caregivers and the members of the public is because there are not really statistical significant differences between the non-clinician groups and the psychiatrists. So I'm just to not over, to be much on the slide, I just put the patients. But here what I want to draw your attention is this one, which is limited evidence of treatment effectiveness. So remember, electroconvulsive therapy has been around since the 1930s, being used for decades now, and patients still think that the #1 barrier is that we don't have enough evidence of the effectiveness. So there's clearly a mismatch with reality here that is important for us to do something about. All right, now let's move to another intervention. What factor do you think patients, so in this case patients, pick as the most important barrier to the use of TMS? Frequency? Lack of efficacy? All right, let's see. So for patients, continues to be treatment efficacy, right? But and I mean, I'm conducting interviews for a different project related to TMS, and it is impressive that I think for all of our participants, they were not aware that this therapy even existed. So let alone that, about the effectiveness, they would have not that much knowledge. So, but in the case of the psychiatrist, what is interesting is that it moves from a stigma to issues about cost and lack of insurance. So it also clearly shows that even though it is approved, there's many other structural barriers that are making this to be considered for psychiatrists as clearly a top barrier to get access to TMS. All right. Now, what factors do you think? We're going back to the psychiatrists. What factor does psychiatrists pick as the most important barrier to the use of deep brain stimulation? Cost? Right, so evidence. So evidence continues to be the #1. And here what I want to draw your attention is if you focus on the top 2 ones, limited evidence and lack of understanding, there's really no significant difference between the psychiatrists and the members of and the patients. Where we see a difference, I mean, it's not one of the top things that they pick, is in the low public trust bar that you can see there. But clearly, I mean, it's not super surprising given that the brain stimulation is still in development, it's not approved for depression, so it is at least it makes more sense that some of the psychiatrists and the patients are aligning in what they see as their top considerations here. All right, now, what do you think patients pick as well, we didn't look at VNS, but what do you think patients would consider the most important barrier to the use of VNS? Evidence, efficacy. All right. Well, that's obviously to be continued. I don't have data on that, unfortunately. VNS was not one of my interventions. But, so with the group here, with Dr. Wilson, which is a HAS group, we're trying to get, funded to be able to ask these questions, specifically looking at vagal nerve stimulation. Now, we know that we have little insights. If you do a quick search on VNS and ethical concerns, my dear colleagues haven't thought that VNS is an exciting technology. So unfortunately, there's not that much literature in neuroethics or in ethical issues in terms of vagal nerve stimulation. So I think we're getting here to a very good piece of the pie where we can really advance the knowledge on what are the different perceptions across different stakeholder groups regarding different aspects, not just barriers, right? Also perceptions of invasiveness or risk and benefits, and what are ethical considerations do people think in regards to VNS. And what is nice is that we already have that knowledge for these other electroceuticals, so we'll be able to map the electroceutical landscape nicely when we do that. And another important thing, as we heard in the talks in the morning, is that vagal nerve stimulation is now being used for a variety of other disorders that are not necessarily just depression, right? So would that really make a difference for how patients and the public and psychiatrists perceive these different aspects when we talk about VNS? So if we talk about depression, would it be different if we talk about diabetes or if we talk about stroke? So I think, again, we have a very nice, timely point where we can start asking those questions as research develops. And so some of the things that I think we're going to be able to draw is there will be similitudes given the nature of the treatment, right? All of these are electroceuticals. So perhaps there is something that, yes, is common across all the electroceutical interventions. So, for example, we know that the use of electricity, some people see it as, it gives life, right? You can think of a pacemaker, you can think of, when you have to resuscitate someone, it can give life. But it can also take life, so when you think of, the electric chair, right? And so people kind of have to go through the boundaries of all of the power of electricity, right? As something that gives and takes life. And then finally, we know that it's very likely that we're going to have differences given the technological and clinical features of VNS, because that's kind of some of the data that I just showed you, right? So there are important differences depending on the intervention. And so some of the lessons that maybe we can draw from all of this data that I provided in terms of a stigma as a barrier. Well, it's hard to know because clearly with VNS, we don't have that level of public media, popular culture, kind of saying, VNS is bad, is used for social control. So we don't have that legacy for VNS. So that could be something actually that we can use as something beneficial to us and use the fact that we don't have that legacy to try to promote a better, storyline for VNS. In terms of lack of information about the intervention, clearly all of these neuromodulation electroceutical interventions, as you saw from the data, at least from the patient perspective, there's really a lot of lack of information and awareness. So much, it's going to continue to be a barrier, so we're going to need to work hard on that end. Time and resource constraints. So that I'm not an expert on VNS, so I don't know how much that's going to play, but that's certainly also an important consideration. The mistrust, I think, as Dr. Wilson mentioned, that's another area that is going to be a barrier that we're going to have to continue working on. Now, facilitators. I think the perception of invasiveness can also be something that could be a facilitator, right? So because it's not in the brain, it's in the vagal nerve. So maybe that's, again, another storyline that we can use to try to, when we talk to patients about it as a line of it's not as invasive. But also clearly being open that that's not the only way in which we should talk about invasiveness with patients. And the social support, right? I think that's just true for all of the different interventions that I mentioned. If we don't have a good social and system support for our patients to get at their appointments, to have time of work and things like that, that's certainly not going to help anyone. So just kind of closing, why is this important? Well, addressing these misconceptions will help us, hopefully, to have, planning mental health resources and allocating priorities. So the title of the session is, equity in neuromodulation. So not everyone will need deep brain stimulation. Not everyone, will need ECT. And so how do we start asking these questions? And how do we start making sure that the things that we know patients need, that they can get to and they can have access to? So with that, I want to just thank my team. I started all in Michigan. Dr. Witch, who has been a part of the scientific advisory board, students, and obviously the participants, both in the interview and survey level, and the survey that obviously provide us with their time and expertise. So thank you.
While Dr. Cabrera's research is close in your mind, we'll start with any questions about her survey research, and then we'll broaden it back up to all the topics of equity. Got a question?
Thank you for the talk. I have a question. So your survey was focused on the kind of physical devices, right, that are delivering electrical energy. So I kind of want to a little bit compare it with maybe pharmaceuticals and kind of their history of advertising directly to patients, right, either through the TV ads or perhaps even those shiny brochures in office visits. Did you guys ever compare kind of one-to-one, and does that make a difference in the patient trust and perception?
We didn't do that at the survey level, but in the developmental stage, one of our questions was to compare it with medication and with psychotherapy. So because we wanted to understand, we need a baseline, right? If we just ask them, well, how do you see invasiveness? But we don't have anything that the patient can draw experience on and can provide their perspectives, it would be hard then to interpret our results. But some of that, I think, for example, in one of the quotes, I have like DVS, patient comparing DVS to medication. So they were able to draw on their experiences, but also to say, okay, how would that compare to medication or to psychotherapy? So what are the two things that we compare? And then in the case of deep brain stimulation, we asked them to compare it if DVS was used instead of for depression, was used for something like a stroke or something else. So we tried to make a difference so people could have a baseline and for us to make it easier to interpret the data.
Just a follow-up question that's related to that, which is about these issues of trust, invasiveness, and evidence. One issue we haven't talked about yet is reviewers as they decide how to promote these things. So you've got clinicians administering them, you've got patients receiving them, and then you've got people sort of planning what the next version of these things looks like. So I'm curious what your thoughts are on sort of reviewer awareness about patient perception on is perceived invasive as opposed to pharmaceuticals. And then a related question, what are the lessons from the COVID vaccine where, again, we've got this efficacy data and yet you've got this resistance that we can take forward to make a better job in explaining and dealing with these issues of trust, evidence, and how to get adoption to be where it should be?
Yeah, I mean, all of, not easy questions in the sense that in terms of the first one, I mean, we need to have rooms where we have a more diverse set of people, right? So if all the people, just with the expertise of, IRB are in one room and all the experts that are actually seeing patients are in another room, they don't know the problems that each one faces. So, the clinicians will always criticize, oh, it's the administrators that don't understand. But perhaps, the ones in the front lines, they don't really understand what are the challenges that administrators have to deal with. So I think having more open and transparent conversations of the challenges, it is important to actually move together rather than just, try to move one each one in their own realm. And related to the second part, I think the issue of trust grows again with having diverse perspectives, right? So I think Dr. Wilson mentioned, how if we have a diverse workforce, then you might have, the nurse or the social worker or the clinician that is also a Latino that goes and talks to the Latino woman and says, from a more cultural sensitive perspective, their own way to get to, talk about the preferences, the values, the things that are important for that population. So we need more of that because just, having a flyer that talks about the therapy, that's not gonna make it for everyone. So we need to be more creative as a society in terms of plan A is not gonna work for everyone. We need to have different prongs of, access and to building information and knowledge across different populations.
Thank you. Very interesting. So is there evidence of, obviously it's in the interest of drug companies to promote existing pharmaceutical treatment. Is there any evidence that they are discouraging these alternative therapies?
Well, I don't want to say yes or no because I don't know. I don't have the data to say yes or no. But I think it's not unthinkable, right? They put a lot of money in having, maybe patients saying, things about, it was horrible with ECT. And who knows if it's a real experience or if it's, the person is getting paid. So it's just really hard. And it's really hard to study from an empirical point of view. How do you know if someone is being paid and is giving testimony? Because you don't want to discredit potential experiences that are true. So that's hard. But I'm just saying that it's not unthinkable given the conflicts of interest and monetary gains, that's the case. But let's not be naive. Device companies are not angels, right? They're trying to push their products, so we need to be careful in both ends.
One of the things that really struck me out of your data is how us as psychiatrists or providers can be so off on the stigma issue because we overestimate the stigma, whereas it seemed like the patient don't necessarily think of it as such a big barrier. And I'm wondering from your study groups, is that a narrative that we tell ourselves to avoid doing some of the harder work at different type of barriers that could be worked on, and instead we're flagging a stigma as being this kind of a omnipresent thing, where in fact, like I said, you're showing that the patient don't necessarily think of it as this much.
Yeah, I think there's two important aspects to that. One is that certainly some of the responses that we got from our participants, not necessarily in this question about barriers, but in the questions about, for example, the ethical issues, or just more into the affective response to these interventions, there's certainly negative connotations. So one of the things that, with other projects is that sometimes the general public in particular, when we talk about a stigma, that's not necessarily a word that everyone, that with certain levels of education will just grasp, oh yeah, stigma. So for us, we can talk about a stigma and we kind of know what we're talking about. Well, I was shocked also when someone told me, what do you mean with stigma? Like it was really, clearly they were not on the same page with me. And so it is possible that it's just our participants are just not framing stigma in the same way that a clinician, and therefore we see a disparity, a difference there. But the other point, to your point, that's true, that's another interpretation. I was really interested when Dr. Wilson shared her data about, that some of the psychiatrists have this implicit bias maybe, in that they are not referring certain populations, or are diagnosing certain populations in ways that, make that referral different compared to other non-Black populations. So again, that I think is both things are in interplay here that make that stigma such an big difference. But talking to my psychiatrist colleagues, one of the things that they encounter is also that, they have tried, they offer it, and they just see that patients go like, no, I don't talk about I don't want that. So I think there's multiple factors, and I don't want to say it's only that. There's probably multiple layers that we need to, peel out more carefully.
Just one other comment. I mean, considering that this is a kind of a peripheral neuromodulation focused meeting, yesterday over beer we were talking about that even in Australia, minorities are mistrustful of healthcare in general, and they too have very high incidences of high blood pressure and diabetes that goes untreated. And so I'm really curious about how much of the same narrative will translate when we're talking about peripheral neuromodulation and the avoidance of it or the racial disparities in it versus it being much more palatable just because we're way outside of the brain and we are talking real medicine, quote unquote, as opposed to psychiatric illnesses.
Yeah, I think for some patients, it's not going to make a difference whether you are in the brain or outside the brain in terms of, as long as it's in the body, that's probably going to be where they draw their boundaries, right? Like everything that passes my skin, no thank you. And that's, we've seen that with, different type of interventions, and some people, that's just how they see things. But in terms of, how do we, if that's comparable to what you mentioned in Australia, the mistrust is going to take us years, right? That building trust in the medical system is not just whether, you have, again, implants that go into your brain or into your nerves. I think it's just the trust that I should trust my clinician, that the clinician really has in mind my well-being. For us, that might sound surprising, but for some populations, that's why they don't almost never go to the doctor, right? Because they don't trust. But there's also another important consideration here, and I think as Dr. Wilson showing her slide, sometimes we want to believe that narrative, that it's just a trust issue. But if we don't do anything to really address some of the structural barriers, how are we going to have trust, right? Like if you cannot ask your employer for time off because you have pain and say, look, oh, you don't have pain, you're just, complaining. So trust starts at multiple levels. Obviously, we need trust with the clinician, but trust needs to come, when trust and advances in this area need to come at multiple levels. And the trust is not going to be gained unless we as a society make it also accessible to even ask and go to clinicians, therapists, and others. And so that to me is like, it's a tricky question because it's not just the patient-clinician interaction that we need to focus on. It goes at I think a more macro level here that we need also to focus.
Great, and we can keep working on with questions for Laura, and we can also widen out to go back to the treatment access disparities and have a chance for people from different stakeholder groups to get up on their soapbox and talk about how they think we can improve access to neuromodulation in the future.
Should I ask the question?
Yes, you can keep asking questions too.
Okay, so this is all very interesting to me. One thing, I grew up in rural Minnesota, so when I talk to people in the public about what I do, they don't actually know anything about it. They don't know that people get stimulated by nerves and that we put electrodes in the brain and that actually works. They still think it's science fiction, right? Mm-hmm. So the understanding point to me seems really important, but obviously it's good that you're doing these type of studies. What I'm curious about is, so when I even think about vagus nerve stimulation, which is what I research, and I've done research on deep brain stimulation, it still feels very experimental. I think it, compared to other things like the pacemaker, which is essentially deep brain stimulation, but you just have the electrodes in the heart. That's an oversimplification, but the point is they're very, very similar, but I would think that the plots that you are showing would be very different for the pacemaker. I'm just curious if you have any data for that, or if you can reference any data to have it a direct comparison between something that feels very familiar and something that I would say does not feel familiar.
Yeah, well, as I said, one of the participants referenced oh, this looks like a pacemaker, right? So they draw on that knowledge. But I don't have the data, but I think if I was if I were to have, part of my survey about pacemakers and part of my survey to deep brain stimulation, yes, it would be a huge difference. Because, so part of the survey, we also have an open-ended box where people can put their thoughts. And a lot of our responses were like, I don't want anyone, being in my brain. So the fact that it's in the brain was a key part of the story. So yes, some of these graphs will look totally different if we were talking about the heart, you name it, that any other organ that is not the brain.
Is this, okay, yeah, so the reason I bring it up, and because you agree with me, and we're trying to think about things to figure this out, what can we learn from how the pacemaker was developed and adopted to figure out how to make, brain devices and nerve devices adopted? Because at some point, I think people probably had a problem with putting electrodes in their heart too.
That is true. So if you were to read the literature of how the public had this mistrust and I don't want to be the first one. So we've gone through that with other type of interventions. But what I think is interesting is that on the one hand, we're telling people the brain is this very complex organ, it's taking decades to know how it works. So I don't think it's the same to say we're going to intervene in the brain where we're still so much unknown and it's so complex than we're going to intervene in the heart. So I think for some people, it's just going to be very difficult to accept that it's the same thing, right? Because clearly, when you stimulate the brain, the type of responses and things that you're creating are not going to be the same that as you stimulate the heart. And so, but how do we create more awareness on, what do we know? What do we still don't know? What things we might never know just because the brain is really complex might help to people to understand, that it doesn't need to be the same. But they can draw on the experience of the past with, again, using electricity in different parts of the body. And I think in my opinion, I think it's going to take time, but I think it's important for us to spend that time informing the different publics, not just the patients, but the different publics that this is happening and it's not science fiction, right?
Thank you.
I have an opinion about that as a clinician to say what can we learn from acceptance of the pacemaker and have it apply to our mental health or neurological disease treatments. Something I do in clinic as a treatment-resistant depression provider means that I have to put their illness in context in terms of severity and dangerousness. Everybody understands with the pacemaker, if you don't put your pacemaker in, you can have a heart attack, you can have complete heart failure, and you can pass away. People don't always think of depression as a medical emergency or a medical urgency that should have aggressive and potentially invasive treatment. And I often frame it that way for patients when we know that depression can be a chronic relapsing illness. It's potentially a long period of time of people's lives that can be greatly affected. And by encouraging them to use more aggressive or invasive treatments early, we're preserving life and preserving function in a way that is similar to a pacemaker, but you have to make them feel that depression is serious enough to act on. Even though people are suffering, it doesn't feel as serious as the potential for a heart attack, despite the fact that depression will also increase your lifetime risk of having a heart attack.
I would just want to also add that, there's clearly a big difference when you think about, let's say the use of deep brain stimulation for Parkinson and the use of deep brain stimulation for depression. So this is, it's not part of this research, but other research that I've conducted has to do with deep brain stimulation in Parkinson patients. And it's, we have kind of, in a way, we have overcome that, that loop in that a lot of patients actually want to have deep brain stimulation for Parkinson. But then it's not only that it's in the brain, right? It's the type of indication that we are addressing. So people will say, oh, it's Parkinson. I can see it stop my tremor. I can see it when I turn that stimulator. You cannot see that necessarily for depression, right? And so I think when we're treating mental health disorders, it's going to be even further work that we're going to have to do compared to other indications in terms of neuromodulation.
Other comments strategies, successes for improving equity.
I have a question over here for both Dr. Cabrera and Dr. Wilson. So you talk, one of the themes in the talk was that time and time again, patients want to hear about efficacy. And I know we talked a little bit about trust already with another question. So what are both of your recommendations for communicating that efficacy to both the public and patients?
You want to go first?
Sure. So as a clinician, I always make sure to emphasize if I am recommending an FDA-cleared treatment that gives it a sense of legitimacy and lets people know that there is some weight of evidence behind it, even though there can be some shakiness in people's overall trust in the FDA. Also, when I'm having informed consent conversations with patients, I try to personalize the discussion as much as possible. If I'm aware of specific symptom clusters that are more likely to respond to the treatment than others, I try to point those out and recognize them if they're present in the patient. And I often do actually describe the treatment studies that led to FDA approval and describe to the patient how well they would have fit in if they were a participant of that study. Many of the TMS studies did include patients who were very ill and had in fact failed electroconvulsive therapy before. So I can tell a patient, even though your personal history includes this, people like you were involved in this clinical trial, and this is how well they did. I think that's my biggest weapon towards trying to increase people's knowledge of efficacy for the treatment.
So for me, I would say, obviously, humans are not so good with necessarily numbers. So if we tell them, well, we have these statistics that, blah, 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 works and this doesn't work. I think what is powerful when we're talking about in particular patients is the stories that we tell about something that works or doesn't work. So one of the things that in another project with DBS, for example, was let's bring patients to talk to people that are considering this intervention, because it's not only important whether it was effective or not. What were the trade-offs? Right? All of this is important for the patient. It's not only that, well, maybe it works perfectly, but maybe the side effects are not that great, and that patient regrets having that DBS now. So I think we have to talk beyond effectiveness just to talk about just the experiences of patients and make them have a more informed decision based on what they know from other patients that are like them.
Spoiler alert, we found similar desires of the patients in our focus group data that you can see in the poster session at poster 99. Yeah.
Working? So thank you first. Fascinating discussion. I think it's really important to recognize that if we don't get the treatment to the people who need it, that we're kind of missing the opportunity of all this work that we do. I was curious if you could comment on how maybe to inform the design of these systems that we're building to help people, particularly like user interfaces or communication to the patient or clinicians to break down some of these barriers, keeping us from giving people the treatment they need.
Mm-hmm. Yeah, I mean, there's different designs that people have been proposing in terms of really bringing developers and bringing together developers and future users early on in the design of these interventions to talk about, because again, I tell this to my students, sometimes you're as an engineer, you have your assumption of like, this is what everyone wants, everyone wants to walk. Well, is it? I mean, we know from other disorders that maybe for people might prioritize that they have better, bladder function than walking. So again, we have to be able to take away our assumptions and talk to the people that really need what we're creating. So that's, it's well documented. So there's different type of approaches on how developers can, engage and partner with potential users when developing. And so I think more and more of this is important. I think what's going to happen in the next session when we have, users coming and providing their experiences is also important, right? Because once a technology is out there, it doesn't necessarily mean that that's it, right? Like there's like a post-approval stage where we need to know, well, are there things that maybe are not functioning the way that we were thinking they will. And so being able to also address after approval those things is important. So having in the loop, engage all the time potential users, caregivers with the developers. I think that's an important component. Was that what you were asking in your question? I want to make sure I...
Yeah, so in my work, I'm trying to design these systems. How do patients actually, how do people interact with the systems that they're using? And I thought it was really fascinating. One of the barriers you were talking about kind of touched on the notion of patient control and whether or not a patient feels like they have a choice or the ability to be in charge of their therapy. And so I was curious if you could elaborate on that, specifically as it comes to usability engineering of the systems that deploy these therapies.
Yeah, I mean, that's only a question that we really ask in the developmental stage, so with our interviews, so we will need to expand to a larger sample to get a better grasp. But for example, some people in the case of the brain implant, right? Like we were asking them, so if you were able to have to program yourself, your implant, would you prefer that or would you prefer like the clinician? And that was like a, half-half. For some people, it was like, no, I wouldn't trust myself to do this. I trust my clinician. But for others, it was like, no, I want to be in control, And so that's tricky, right? When you have half of the population want to have control and half doesn't. But I think you as a developer being able to have a system that might enable both phases, right? Like for patients that want to have control, you can give them control within the parameters that will allow them to keep safe. And for those that doesn't, you have the clinician that can do that. So having that as a developer in mind, I think is an important component, giving options.
Oh, question for you. I really appreciate this talk. In terms of the continuum of care and how patients are accessing these kinds of interventions, have you looked at what the understanding or perception of stigma with primary care providers and those initial, where those referrals are coming from to those psychiatrists? A lot of times, those are the providers who are doing the history and physical prior to those more invasive procedures, and what that dynamic or their understanding of the efficacy of these devices is.
Yeah, I unfortunately we didn't go to that population, but I think that's clearly the next group to involve, right? Because especially in the setup that we are in the US, primary care providers are, in a way, an important part of the gatekeeping, right? Because you don't have psychiatrists in many areas of the states. In very rural areas, you don't have access to many psychiatrists, so they will be the gatekeepers. And so understanding where their stigma comes or where their perceptions come of these technologies is going to be very, very important if we really want to make this accessible. So that's a very, very important group. But I didn't touch on it, but that's certainly an important group.
So I realize I'm keeping everyone from lunch, but what's the involvement of funding agencies here on equity and inclusion? I recognize that's probably a very touchy subject because you are all getting funding from NIH and so on and so forth. But we've got the BRAIN initiative rolled out their plan for enhancing diverse perspective mandate in all funding proposals. How do you see equity being included in something like that? Or is it going to be another check the box, or people are going to invest in those types of plans and mandates from funding agencies?
Fabulous question. Fabulous question. I really see the role of funding agencies. They have multiple roles in this situation. As we discussed in increasing workforce diversity, that having pathways for diverse trainees and early career faculty of color to feel established and supported in their early career research is important. So funding agencies, expanding the use of those diversity supplements, and making more funding agencies open specific pathways to encourage trainees of color, I think is really important. when setting budgetary requirements, when you're looking at populations that have been historically underserved, consider boosting your budgets to help overcome additional logistical challenges such as childcare and transportation or translation services that would make it difficult for certain populations to participate in a clinical trial. It's very hard to do those things inside the regular standard budget with everyone else. In the small qualitative studies that I have been designing here in the Twin Cities area, it's also been really important that we demonstrate the value of the community's participation in our research. And sometimes that means demonstrating the value in direct compensation for participants and kind of raising the ceiling on that, knowing that people are giving up working hours to have a livable wage to participate in this research and to not expect quite so many people to participate in uncompensated research. These are some of the ideas that have been swimming in my head to talk to funding agencies about.
I mean, obviously there's different aspects. I won't touch on the ones that Dr. Wilson already mentioned. But I mean, I don't want to be too critical here, but if we talk about the BRAIN initiative, just think of the type of interventions that get funded, right? So, as I mentioned earlier, not everyone is going to need a DBS, fortunately. And yet, there's so much investment. And so, I think me and other colleagues are trying to also say, well, we need more investment in other things that are not going to be the high fancy technology, but are things that are going to get to equity in terms of, healthcare. It's important to develop these technologies, but we also need to be aware that they're not for everyone. Fortunately, they're not for everyone. And so when the funders have that more open mind that, okay, great, we need to fund, brain-related technologies, but be more aware of which ones are going to be able to really impact the most instead of just a few is going to be key.
Yeah, taking that public health perspective and trying to strategically deploy technologies in specific regions based on population density would make a lot of sense. And it doesn't seem like very fancy science to do it, but it's very big public health and population level benefits. And I think that should be a focus for funding agencies to generate population level benefits more rapidly.